Welcome to everybody. Today we will talk a little bit about CT perfusion to assess aeration and perfusion. I am Professor Pelosi. I'm head of the Department of Anesthesia and Critical Care at the San Martino Policlinico Hospital in Genoa. I have no conflict of interest to declare for this specific talk. Why pulmonary perfusion matters? Because pulmonary perfusion is a relation between the interaction in the heart and the lung and have major effect on general hemodynamics. This may be associated with an increase in pulmonary vascular resistance due to the changes in the right ventricular afterload or left ventricular preload and thus affecting cardiac output. Has an impact on venous return to the heart and specifically to the right ventricular preload. And also it's very important to determine ventilation perfusion matching, which is a key determinant in pulmonary gas exchange, and thus sharing the effects on shunt due to atelectasis or VQ mismatch due to the impaired oxygenation and or increasing functional dead space. There are different lung imaging techniques we will not discuss into detail in this specific lecture. I will refer mainly to perfusion CT scan and dual energy computed tomography. Other techniques like electrical impedance tomography and lung ultrasound can be used at the bedside. We have to remember that regional perfusion may be affected by hypoxic pulmonary vasoconstriction, airway pressure, or posture. And different causes may lead to changes in regional perfusion, like vasoconstriction, swelling of the endothelium, obstruction, and collapse due to the increased lung weight. And they may be associated with different effects on high VAQ, low VAQ, or shunt. During anesthesia, it has been clearly shown that perfusion in supine position in normal subjects is highly distributed in the more dependent lung regions associated with a reduction in ventilation. And this leads to an increase in the low VAQ areas in the most dependent part of the lung and areas of higher shunt. While in the non-dependent part of the lung, we observe a reduction in perfusion with increasing ventilation leading to an increase in the VAQ. In ARDS, as shown here in different colors, regional perfusion is mainly distributed in the dependent lung region where consolidated or atelectatic regions are present. Here you can see different images in ARDS patient mechanically ventilated, and in red indicates higher perfusion and blue less perfusion. You see that the majority of patients present higher perfusion in the dependent part of the lung, explaining higher amount of shunt. And in fact, the PO2-FL2 ratio is associated with the proportion of perfusion of voxel with a fractional water higher than 0.7. PEEP may have different effects on perfusion. Again here, higher perfusion is represented with yellow color, lower perfusion, dark color. And you see that at end inspiration, peak apnea, or end apnea at end expiration, and lower PEEP. Anyway, perfusion, again, is mainly distributed towards the lower part of the lung, especially when pressure are increased. And this is even more evident when we increase the PEEP level with an increase in perfusion in the dependent part of the lung. This might explain why higher PEEP level sometimes may be not associated with an increase in oxygenation, due to the fact that higher perfusion is diverted towards the most dependent part of the lung. And only if recruitment occurs, this is associated with improvement in oxygenation. These are data that we performed some years ago in the laboratory of Dresden of Professor De Abreu. This is the aeration in a normal lung, and we measured the regional distribution of perfusion by a specific microfluorescent technique. And you can see here that the distribution of perfusion was mainly distributed in the dependent part of the lung in normal lungs to the controlled mechanical ventilation, as well as occurs during spontaneous breathing. In injured lung during controlled mechanical ventilation, as you can see here on the left, there is an increase in the red area, so non-aerated areas, and poorly aerated areas in yellow. And the distribution of perfusion is much more homogeneous in the dorsal ventral axis. Thus, there is an increase in the shunt, so perfusion in the dependent part may be anyway blunted due to the vasoconstriction or compression of the capillaries, while another amount of blood perfusion is in the poorly aerated regions, leading to alteration in the VQ. Interestingly, when animals are moved towards more assisted mechanical ventilation, in this case pressure support, even if there is no major changes in the non-aerated and poorly aerated lung regions, there was a shift towards the non-dependent part of the lung of regional perfusion. So this indicates that the improvement in oxygenation, moving from controlled to assisted mechanical ventilation, might be due to a redistribution of perfusion from dependent to non-dependent lung regions and no alveolar recruitment. So this connection between recruitment and improvement in oxygenation according to the distribution of regional perfusion. So overall, how is the aeration and regional perfusion in ARDS? We found PEEP in controlled mechanical ventilation. As you can see here, there is more perfusion in the more dependent lung region, while there is more ventilation in the non-dependent lung region, leading to a higher VQ and also to increased shunt due to the higher perfusion in non-aerated lung. If we apply PEEP and we observe a recruitment in the dependent part of the lung, the perfusion remains in the dependent part of the lung, but there is an increase in ventilation in the most dependent part of the lung, leading to a reduction in shunt and an improvement in the VQ. On the contrary, during assisted mechanical ventilation, we can have recruitment or no recruitment, but in different cases, we can observe different redistribution of perfusion. When we have recruitment, we have a maintainment of perfusion in the dependent part of the lung, so an improvement in the VQ and a reduction in shunt. On the other side, when there is no recruitment in assisted ventilation, we can observe a redistribution of perfusion towards the aerated part of the lung. In supine position, the distribution of gas volume was shown here in dark gray as more uniform in prone as compared to supine. But interestingly, the perfusion, again in dark side, is much gravity dependent in supine, while more homogeneously distributed in prone. Overall, we can model the response in oxygenation in prone in two settings. When oxygenation improves and there is no recruitment in consolidated areas in prone, usually there is no change in ventilation and regional ventilation, and so we can observe no change or increase in PCO2. So when PO2 increases and PCO2 does not change or increases, this suggests that the improvement in oxygenation is just due to a redistribution in perfusion. On the contrary, when oxygenation improvement is associated with a reduction in PCO2, and thus we can expect an increase in the regional ventilation, this is likely associated with recruitment in the dorsal lung regions. We recently investigated by dual energy computed tomography COVID-19 patients. This was one of the first images that we got in our patients. And this is a very typical images. In the top, the so-called phenotype 1 with ground glass lesions and less consolidated areas, and on the right, the pulmonary blood volume measured by the dual energy computed tomography, and the lower panel, phenotype 3, indicating consolidated and ground glass areas with a different distribution of perfusion. We found that normal lungs have a weight of around 800 grams, RDS lung around 2 kilograms. The COVID-19 phenotype 1 on the top on the slide, 1 kilo and 100 grams, and phenotype 3, 1 kilo 600, 300, 400 grams less as compared to normal RDS. When we look at the survival and non-survival in terms of lung tissue, pulmonary gas volume, and pulmonary blood volume, as shown here in blue, hyperaerated tissue, green, normally aerated tissue, orange, poorly aerated tissue, red, non-aerated tissue, and in dash with perfusion defect. We found a non-survivor versus survivors showed lower gas volume, 1 liter and a half versus 1 liter and 900, lower normally aerated lung tissue, higher total lung mass, 1 kilo and 600 grams versus 1 kilo 100 grams, more blood volume distributed in poorly aerated tissue, increasing low VQ areas, and a larger amount of perfusion defects in poorly and non-aerated lung regions. When we look at ventral, middle, and dorsal, we found that the distribution of aerated lung tissue decreased, but the distribution of non-aerated lung tissue increased from non-dependent to the dependent lung regions. The percent distribution of pulmonary blood volume followed a non-gravitational gradient, increasing low VQ areas. The percentage of perfusion defects in the non-aerated lung tissue increased from non-dependent to the dependent lung regions, and we also observed higher shunt in non-aerated lung regions. The same was when we look from apical, hilar, and caudal region, when we found a distribution of aerated lung tissue decreasing while the distribution of non-aerated lung tissue increased from apical to caudal lung regions, while the percentage distribution of pulmonary blood volume, so lower VQ areas, and the percentage of perfusion defects in non-aerated lung and shunt increased from apical to caudal lung regions. Interestingly, we found that alteration in the aeration were associated with D-dimer and C-reactive protein, while poorly aerated lung mass were associated with compliance, oxygenation, and CO2. We look also at the effects of PEEP from PEEP 8 to 16, as you can see here. We found that the increase in gas volume was around 400 milliliters, and total lung volume very similar. Interestingly, we did not find any major recruitment, less than 2% when we applied PEEP from 8 to 16, while an increase only in normally aerated tissue and hyperinflation. So poor viral recruitment with higher PEEP, 16 centimeter water, was observed in less and more severe cases of COVID-19 pneumonia. To conclude, I propose the Genoa aeration perfusion model in RDS and in normal lungs. In normal lungs, we have more ventilation in non-dependent part of the lung as compared to the dependent part, with more perfusion. When we increase PEEP, we have overinflation and squeezing of the perfusion. When we prone the normal subject, we have maintenance of perfusion in the dorsal lung regions. In conventional, traditional RDS, we have an increase in lung weight with atelectasis in the dependent part of the lung with more perfusion in the dependent part. And when we apply PEEP, we recruit this part of the lung, and we have observed also an increase in perfusion. When we prone this patient, we recruit the dorsal lung regions, maintaining perfusion in the dorsal areas. So in RDS, we have an increase in edema, atelectasis, lower compliance, higher perfusion in the dependent lung regions, recruitment with higher pressure, and response in oxygenation is associated with better aeration. It has recruitment, but not perfusion redistribution. In COVID-19 pneumonia, and especially type 3, as you can see here, we have consolidated area in the dependent part of the lung and Gauss-Grant areas in the middle part of the lung, while normal inflation in the non-dependent part. And some areas are hypoperfused or no perfused, likely due to thrombosis, and there is a mismatch in the regional perfusion. When we apply PEEP and we observe improvement in oxygenation, this is only due to a redistribution of perfusion and non-alveolar recruitment, and when we prone this patient again, the improvement in oxygenation is just due to a redistribution of perfusion and not recruitment. So COVID-19 pneumonia is a typical primary RDS with pneumolysis, and gas volume is substituted by cellular necrosis, cellular infiltration, and fibrosis with major consolidation and higher perfusion in non-dependent part of the lung regions with poor or no recruitment with higher pressure. Thus, the response in oxygenation is associated with redistribution of perfusion but not better aeration. Hypoxia in COVID-19 is thus due to lower VQ in aerated, non-dependent, and poorly aerated lung tissue due to increased perfusion, and higher shunt in non-aerated lung tissue with microthrombosis effect that sometimes may be partially protected. So to conclude, regional pulmonary perfusion markedly affects gas exchange. New techniques are available, some of them also at the bedside, to measure regional perfusion. Regional perfusion explains gas exchange changes and the effects of different types of ventilation. Regional perfusion explains gas exchange of COVID-19 pneumonia, and response in oxygenation may be associated with regional perfusion changes and not recruitment. Thank you very much.